Good morning to all. Today I am discussing about review of liver diseases in inborn error of immunities. So outline of my discussion would be introduction of the immune system, role of liver in the innate immunity, classification of important primary immune deficiency syndromes, clinical presentation and common pathological findings of the few of the primary immune deficiency syndromes with liver involvement. So first of all, I am discussing about differentiation of the neutrophils and monocyte from the hematopoietic stem cells. The first step is in the bone marrow, the hematopoietic stem cells differentiate to the common myeloid progenitor cells and further differentiate in the granulocyte monocyte progenitor cells. And in the one hand, it leads to development of neutrophils that helps in the phagocytosis and killing of the microbial organism with burst of reactive oxygen species. On the other hand, granulocyte monocyte progenitor cells lead to differentiation in the monocytes and that further differentiate in the dendritic cells and tissue macrophages. This also helps in the phagocytosis and killing of the microbial organism. So the role of liver in the immunity, the hepatocyte secretes albumin, clotting factors, and various acute phase reactants along with complement factors. Kupffer cell helps in the apoptosis of CD8 T cells and also secrete the inflammatory and anti-inflammatory mediators. The sinusoidal endothelial cells plays a major role in tolerance with various antigens. It also inhibits the CD4 T cells. The dendritic cells plays as antigen presenting cells of in the liver. So how the liver maintains its local homeostasis in the presence of acute injury or infection in the liver because of some pathogen. The hepatocyte recognize the infectious agent or injury to the hepatocytes that cause releasing of direct associated molecular patterns and microbial associated molecular patterns. So this also stimulates the surrounding hepatocytes and liver sinusoidal endothelial cells that lead to recruitment of the leukocyte in the local environment of the hepatocyte, and liver sinusoidal endothelial cells further differentiate into the myofibroblast and leads to synthesis of the extracellular matrix and cause fibrosis. After this repairing process starts and tissue remodeling occurs, and this causes resolution of the fibrosis and inflammation at the hepatocyte level. If this repairing process does not start, this leads to ongoing chronic fibrosis and may develop in the cirrhosis or secondary sclerosing cholangitis. So defect in the innate immunity occurs at the two levels. One is that the phagocyte cells in the patient with asplenia or in the patient with severe congenital neutropenia, impaired adhesion in the patient with leukocyte adhesion deficiency, impaired killing of the microbial organism in the patient with chronic granulomatous disease, complement deficiency like deficiency of the classical and alternative pathway of the complement system. Defect in the adaptive immunity occurs at the three levels. At the T lymphocyte level, there is impaired development in the patient with SCID and DIGEAUX syndrome, impaired survival and migration of the T lymphocyte in the patient with SCID hyper IgE syndrome, impaired B cell development in patient with X-linked or autosomal recessive agammaglobulinemia, impaired function of the B lymphocyte in patient with hyper IgM syndrome and CVID and IgA deficiency. Also, there is the third pathway of the adaptive defect in the adaptive immunity is the defect in regulatory pathways like HLH and IPEX and APASET syndromes. So primary immune deficiency, more than around 200 conditions of the primary immune deficiency has been identified with more than 150 gene mutations. The prevalence varies from 1 in 750 to 1 in 1 lakh, depends on the primary immune deficiency disorder. The disorder of innate immunity occur in the 10% of the patient and disorder of adaptive immunity occurs in the 90% of the patient. Hepatic involvement in primary immune deficiency manifestation can be categorized in the 4 categories. One is the recurrent infections, inflammation, increased autoimmunity or increased risk of malignancy. The majority of the liver disease involvement in patient with primary immune deficiency mimic like original form of a liver disease like nodular regenerative hyperplasia or primary sclerosing cholangitis, because majority of the patient at the time of diagnosis of liver disease had absence of classical features of immune deficiency. So hepatic manifestation in the primary immune deficiency, there are basically 4 types of primary immune deficiency. In the combined T and B cell deficiency like SCID, there is increased risk of autoimmune hepatitis, increased risk of B cell lymphoma. In patient with hyper IgM syndrome, there is increased risk of recurrent cryptosporidium parvum infection leading to secondary sclerosing cholangitis and nodular regenerative hyperplasia. In patient with autoimmune antibody deficiency like CVID and XLA, there is increased risk of nodular regenerative hyperplasia and viral hepatitis and autoimmune hepatitis. In patient with phagocytic defect, there is increased risk of recurrent liver abscesses, granulomatous hepatitis and non-cirrhotic portal hypertension also. In the presence of endocrine involvement like IPEX syndrome and episode syndrome, there is increased risk of autoimmune hepatitis in around 50% of the patient with this syndrome. Coming to the prevalence of liver disease in patient with primary immune deficiency, this study from King's College, out of 147 patients of primary immune deficiency, they shown that around 30% of the patient had some form of liver involvement that was more prevalent in common combined immune deficiency with hyper IgM and CVID rather than isolated hyper IgM or CVID immune deficiency. These patients had, majority of these patients had asymptomatic hepatosplenomegaly with around 30% of the patient had positive autoimmune liver markers. And the same study showed that recurrent cryptosporidium parvum infection was documented in 44% of hyper IgM syndrome, and sclerosing cholangitis was documented in around 60% of the patient with liver disease in this cohort. The histology of these study patients showed biopsy-prone sclerosing cholangitis in 50% of the patient with liver involvement and graft versus host disease in around 10% of the patient with liver involvement. Hyper IgM syndrome is one of the important cause of immune deficiency. This is X-linked disorder, and this occurs because of mutation in the gene encoding CD40 ligand. The CD40 ligand helps in interaction of T helper cells with B cells, leading to production of the antibodies, particularly the switching of the isotype of the antibodies from IgM to other type of antibody like IgG and IgE. In patient with hyper IgM syndrome, there is deficiency of the CD40 ligand, and there is no interaction in between T helper cells and B cells. So there is lack of switching of the isotype from IgM to other type of antibodies. There is normal function of T and B cells, but there is increased elevation of the IgM, but no synthesis of other type of antibodies. This study of 79 patients of hyper IgM syndrome showed that around 15% of the patient had some sort of liver involvement in the form of hepatitis or sclerosing cholangitis. And in the patient with sclerosing cholangitis, around 80% of the patient had evidence of recurrent cryptosporidium parvum infection. The liver abscesses are very rare in patient with hyper IgM syndrome. Still, there are few of the case reports has been described in the literature. The patient present with recurrent amoebic, bacterial and fungal infection with poor or no response to the conventional IV antibiotic or antifungal treatment. Further workup showed low IgG and high IgM consistent with hyper IgM syndrome. So this study of 24 patients in hyper IgM syndrome who require hematopoietic stem cell transplantation showed that around 80% of the patient had some sort of liver biochemical abnormality in this cohort, and around 50% of the patients showed chronic hepatitis. Granulomatous disease was found in around 13% of the patient. This study showed that presence of liver involvement in patient with hyper IgM syndrome was associated with poor survival as compared to the patient who had no liver disease after hematopoietic stem cell transplantation. So hyper IgM syndrome classically causes secondary sclerosing cholangitis. Still, there are few case reports described in the literature with association of primary sclerosing cholangitis and hyper IgM syndrome with autoimmune hepatitis and hemolytic anemia in a girl who received IVIG treatment with prophylactic antibiotic and steroids. In the follow-up, there was complete normalization of the immune globulin profile. Also, there was decreased reduction of the incidence of infections and normalization of the liver functions also. CGD is one of the important cause of immune deficiency. This is also X-linked and autosomal recessive. There is defect in the gene encoding phagocyte oxidase that cause defective neutrophil function. Because of the defective reduction of the NADPS, there is less oxidative burst in the phagocyte, cause in the normal individual, there should be rapid lysosomal fusion and degradation of the phagocytes in the normal individual with the less sufficient macrophage, and there should be increased anti-inflammatory cytokine release and no evidence of autoantigen presentation. There is decreased risk of autoimmunity. On the other hand, in patient with CGD, there is no reactive oxygen species, and there is slower lysosomal fusion and slower degradation of the microbial organism and phagocytes. There is increased synthesis of the pro-inflammatory cytokine like interleukin-1. There is defective clearance of the apoptosis, and it may lead to presentation of the autoantigens and increased risk of autoimmunity. So, patient with CGD, they most commonly present with recurrent liver abscess because of the bacterial infection like Staph aureus, Pseudomonas, and Nocardia, and they also can have fungal infection like particularly the Aspergillus fumigatus followed by Candida species. So, this is study European study of 29 patients out of around 450 patients with PID. Around 29 patients were CGD patients. This shown that recurrent liver abscesses was found in more than 30% of the.
What is the age?
This is adult population. Adult population. Yeah. So the recurrent liver abscesses was found in around more than 30% of the patient. Apart from the liver abscesses, another study of 194 patients with CGD showed that around liver abscess was around in 35%. Another form of liver involvement like drug-induced liver injury because of predominantly associated with the overuse of antimicrobials was found in around 15% of the patient. Asymptomatic hepatosplenomegaly was found in around 30 to 56% of the patient. Biopsy of these patients showed presence of granuloma and venopathy in around 75 to 80%. Presence of nodular regenerative hyperplasia in around 30% of the patient with the CGD. CVID is one of the most common cause of immune deficiency, and the multiple mutations has been described associated with CVID. This leads to inability of the B cell and plasma cell to produce antibodies, and also there is defect in the T cell maturation. This causes recurrent infection, or increased risk of autoimmune phenomena, and also there is increased risk of malignancy. So this review of 6 studies showed the large population around 250 patients in a study showed that variable form of liver involvement was present in around 10 to 80% of the patient in the form of asymptomatic hepatosplenomegaly, unexplained cytopenias, and increased liver stiffness on the evaluation. Granulomas are rare in patients with CVID. The overall evidence of granuloma in the CVID patients is around 8%. The most common site of granuloma formation is lungs in around 54% of the patient. The hepatic granuloma can be identified in around 34% of the patient with liver involvement. The primary sclerosing cholangitis patient is also reported associated with CVID patient with underlying ulcerative colitis and in the presence of recurrent sinopulmonary infections. Another primary immune deficiency leading to liver involvement is X-linked gamma globulin. This is Bruton's defect in the Bruton's tyrosine kinase, The incidence is 1 in 1 lakh live births. The predominantly affect the male infants with recurrent sinopulmonary infections. There is a reduction in production of the whole class of the immunoglobulin, and hepatic manifestations are recurrent increased risk of recurrent viral infection, and also there is association of the non-cirrhotic portal hypertension and veno-occlusive disease. So this analysis of 21 patients of X-linked agammaglobulinemia found that around 29% of the patient had evidence of nodular regenerative hyperplasia with liver involvement in XLA. SCID is one of the X-linked primary immune deficiency, and there is a deranged lymphocyte development and defective function of the lymphocyte. And one of the autopsy finding with the patient of SCID and DIGER syndrome showed that a graft versus liver disease was present in around 50% of the patient, followed by non-specific viral infection in the form of CMV and adenovirus. The episode is the autoimmunity polyendocrine involvement candidiasis and ectodermal dysplasia. One of the largest study of the 45 patients with episodes showed that around 40% of the patient had evidence of autoimmune hepatitis, and the majority of the autoimmune hepatitis were diagnosed before the development of classical features of primary immunodeficiency in this patient. Other form of immune dysregulation is HLH. This is perforin deficiency leading to impaired function, primary or secondary perforin deficiency leading to impaired function of the cytotoxic T cells. Impaired function of the cytotoxic T cells leading to increased cytokine storm, leading to conversion of the macrophage to the lymphohistiocytes and increased lymphohistiocytosis. The liver involvement with HLH is predominantly part of the multisystemic involvement, and hepatosplenomegaly can be found in around 80 to 100% of the patient with HLH. Elevated trans aminoacids can be seen in around 30% with high bilirubin in around 30%. So this review of around 11 cases with primary liver HLH, they found that the primary involvement of the liver with HLH associated with the high mortality in around 54% of the patient. This study of pediatric population with liver involvement in HLH, they found that almost around 90% of the patient had biochemical evidence of involvement of liver in HLH patient, and this is the PALF group data of 109 cases from ILBS. They found that out of 109 cases, 8 patients had evidence of HLH at the time of diagnosis of acute liver failure. 3 was because of dengue related, 2 were HIV related, and 2 were primary HLH. So conclusion, primary immune deficiency is present with wide spectrum of liver disease. Nodular regenerative hyperplasia is the most common form of liver involvement in primary immune deficiency. And patient with unexplained causes of liver disease should be at a high index of suspicion in to suspect of underlying primary immune deficiency. In the patient who present with recurrent liver abscess, primarily we should evaluate for CGD and hyper IgM and CVID and episode. This is the algorithm of inborn error of immunity patient. One should look for sign of liver disease. We should do liver, imaging of the liver and a biochemical test of the liver to find out the type of liver injury, whether it's hepatocellular or cholestatic. In patient with hepatocellular liver injury, complete viral and autoimmune profile should be done. In the cholestatic injury, we should suspect drug-induced liver injury or sclerosing cholangitis. And in patient with persistent abnormality of the liver function, we should do liver biopsy to find out evidence of nodular regenerative hyperplasia or fibrotic liver disease. Further monitoring for the complication in the form of the liver disease in the form of varices and ascites should be done. Thank you.